Thank you. My disclosures. So I think from the clinical perspective, as one of the clinicians on the panel, as we've had these discussions and thought about it, I've definitely gone back to just how we think about obesity and how we define it in clinical practice. And I think that for most clinicians, particularly those who have an interest in obesity or weight management, we have moved beyond the BMI, even though the BMI is the first thing that we see. But we're not just talking about the specialists, the people who have published, the people who attend these meetings. We're talking about all clinicians, and so that's a very, very, very large group. And how do we move the industry, the healthcare industry, at the front door to the interface to patients? And sometimes that can be an opportunity or a barrier to care for patients that need it. The definition, there are many definitions to obesity. This is the one that is one of my favorites from the Obesity Medicine Association, that defines it as a chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces and results in adverse metabolic, biomechanical, and psychosocial health consequences. And when we think about this as a full definition, I think the question of can BMI completely be equated to that answers itself, right? Because we know that just looking at a number of height versus weight does not capture that. Again, we've had sessions this morning talking about limitations and some of the things that I discussed with my patients. One of the questions I had for one of the patients who shared her story with us was, how does it seem to you as a patient when you're presented with this information? I will tell you that many of the patients that come to see me, I will always ask them, they come to see me for weight management, and I'll say, how much weight would you like to lose? What's your goal? Where are we trying to go? What would be success for you? And some percentage of them will say, well, what's the normal weight for me? What weight should I be? And they automatically go back to the BMI scale that's in front of them. Sometimes it's a sheet, sometimes it's on the wall. We don't have it on the wall in our clinic, but they point to their height and they say, that's the weight that's normal for me. And oftentimes it's a weight they haven't seen since high school. It's a weight that seems out of touch for them. And so we have to really undo a lot of unlearning for patients. And these are patients who've lived with a condition that I haven't personally lived with, and I'm trying to work with them together for us to have a shared understanding and have goal settings. So when we talk about the knowledge around that BMI, does not always link to adiposity, that you have those who may have elevated levels and not have the adiposity that we're looking for on the physiologic or pathophysiologic level, and then the ethnic differences. And I think there are certain groups where it's almost become a common theme, where it's like, I don't even want to engage in a discussion around BMI or my weight because I've never seen anyone in our family that has aligned with this number, and it becomes a challenge. So when we go back to that definition, if we're only thinking about BMI, that's really the only part that's highlighted in yellow that we're talking about. And we're not even talking about it completely, because once again, we know that BMI can be an estimate of the body fat or the adiposity, but as we've learned this morning, there are many cases where it is not. So then what about the rest of this definition, right? None of this is captured. How can we capture that, and how can we explain it to patients in a way that makes sense? I think in our earlier sessions, particularly with Dr. Ard, when you have BMI that is, it's easy to do, it's in your EMR, and when you have other options that are costly, that can have radiation exposure to patients, that are not accessible to patients with a variety of insurance or not insurance, you have to think of something that's going to still meet the mark. And so what is the biggest issue, right? When we think about disease control as a primary care physician as well, the reason that we even talk about disease is because I'm talking about health outcomes. I'm talking about longevity. I'm talking about living your best life, your quality of life, your years of life. That's the only reason I'm talking about anything on the problem list. And so when I'm talking about obesity, is it just of how you look, the number on the scale, or are we talking about, is obesity to the point, or is this a condition that is going to affect your goals for your personal health, your personal longevity? And with that focused approach, it allows us to say, how can we identify individuals who really comprehensively have this disease process and are at highest risk for morbidity and mortality? That does not necessarily mean highest risk for another disease process, right? If we only think about obesity as a risk factor for everything else, then we miss the mark as well. And so accurately identifying and allowing for prevention and treatment to be targeted. We know the cost, right? We know we also heard about that estimated cost. We're even covering 5% of folks, right? And so that is a huge challenge when we think about it. Of course, many people are familiar with the Edmonton obesity staging system. Some people use it, some people do not. I'm not presenting this as the alternative, but I think what we can learn from that staging system is a way of looking comprehensively of that individual, where we're able to rank the severity of obesity based on clinical assessment of a number of weight-related health problems. It's a framework for prioritization, and it can also be a predictor of risk. So when we think about this again, this is what clinicians do in their mind. The challenge with BMI is that it's easy to have that cut point. If it's that number, we can give this medication. If it's that number, we can take this patient to surgery. But we know as clinicians, when we diagnose, there's that art to medicine. We're not just looking at the number on the scale. A patient with diabetes that has a 7.1% and no other issues, and someone that is 6.9 and just had a stroke and had an MI, my approach to their diabetes management is going to be very different. That A1C is only a part of it. I think when we think about hyperlipidemia, we've seen the largest part of it, where we're no longer saying you have to be under 130 for your LDL. We're looking at a whole risk score. And so when we think about obesity, thinking about the medical conditions, are there other comorbid effects? Is there end organ damage? Is there end stage level? What is the mental and psychological effect? This is another piece. You have patients who are coming seeking treatment because of the mental effects that a society of stigma related to a condition that they have that they cannot hide from others is affecting them. But that person cannot get treatment unless a number is a specific number on the scale. Also, the functional component that came up in a question talking about joint pain, talking about energy. These are all other things that we can't simply look and put on a scale or on a number. So we also have data behind some of this, right? And so when we look at the NHANES data, looking at the Edmonton scaling system, even in the different classes of obesity, we see here that when we talk about morbidity and mortality, those who are in that first category where you're not seeing those comorbid conditions, you're not seeing that psychological or those physical fat forces being of effect, you can see here that we're not really seeing that morbidity and mortality. But if you were only looking at the BMI, you were missing that link to risk. So I think it's an opportunity for us to be open-minded, right? Does that mean we throw out BMI completely? I think it's a larger part of what we're looking for. And if we really zone in back to what our definition is and always reflect on, is what we're using actually going back and covering every one of these areas in green? Are we doing a fair shake for our patients, for our profession? And so I think it's a conversation I'm glad we're having today, and one we will definitely need to continue.